Listo. Buenos días. Continuando con el programa de hoy, a nombre del señor embajador de la UNESCO, Jorge Herrera Ramos, y chairman del World Congress of Neurosurgery UNESCO ASNET, Walter E. Dandy, in honor of Professor Yarza Hill, a quien agradecemos por la organización de este magno evento, así como a la doctora Deyanira Capi Casillas, chairman del capítulo ANSI-PN, al doctor Salim Abdurraouf, chairman de Walter E. Dandy Neurosurgical Society, al doctor Baba Kateb, chairman de la Society for Brain Mapping and Therapeutics y de Brain Mapping Foundation, todos ellos vice-chairmans del comité organizador, y al doctor Parménides Guadarrama Ortiz, chairman del Centro Especializado de Neurocirugía y Neurociencias México. Es para mí un honor presentar la siguiente ponencia a cargo del doctor Álvaro Córdoba, quien es miembro de la Clínica Neuroquirúrgica AKH en Neurocirugía Vascular de la Universidad Médica en Viena, miembro activo de la Sociedad Walter E. Dandy y en el Departamento de Neuroendoscopía Cerebrovascular de la Universidad de San Luis, Missouri, en Estados Unidos, y miembro activo de la Sociedad Austriaca de Neurocirugía de Viena, Austria. Dr. Natalie?
Yes, thank you, Dr. Lima. Hello everyone, welcome back to the World Congress of Neurosurgery, UNESCO and Walter Dandy Society in honor of Professor Ghazi Sargil. So on behalf, I'm talking on behalf of the Ambassador of UNESCO ASNET, Mr. Jorge Herrera Ramos, to whom we are grateful for organizing this event and for gathering all of us together. So today also we have the Vice President of the World Congress is Dr. Deyanira Kapi, President of the WNS Medical Student Chapter, Dr. Salim Abdulraouf, Global President of Walter Dandy Society, Dr. Babak Kateb, President of the Society for Brain Mapping and Therapeutics and Brain Mapping Foundation, also honorary chairmen of the committee, Professor Nasser El Gandour and Professor Marcus Rota. And also we are grateful to Dr. Parmenides Guadarrama Ortiz from the Specialized Center for Neurosurgery and Neurosciences in Mexico. So today we are having with us Professor Alvaro Cordoba, who has a really great profile of his all of his work in different places and also in Vienna. He is also active member of and faculty of the Walter Dandy Society and St. Louis University Cerebrovascular and Neuroendoscopy Department in Missouri, active member of the Austrian Society of Neurosurgery in Vienna, Austria, past president of the Latino American Study Group on Neuroendoscopy, and ex-member of the editorial board of the Flank, and ex-member of the WFNS Committee on Neuroendoscopy. So Professor Cordoba, you have a really great background behind yourself, so we are sure that you will give us a really great presentation about the Muslinoma after creep wrapping of cerebral aneurysm. And also today we have the Professor Claudio Jampolsky, so we are grateful to help him with dealing with some technical problems and to be the moderator with us today. So yes, Professor Cordoba or maybe Professor Jampolsky would like to say a few words, so I can pass the ball to you now.
Oh, thank you, Natalia. Thank you, everybody. It's a pleasure to be here. Just to introduce briefly Professor Alvaro Cordoba. We are happy to have you here, and it's your time to show you your experience with this very, very rare pathology. Please, Alvaro.
Thank you so much to all. I'm very most grateful with you, Claudio, all of the colleagues, the young colleagues of this World Congress. Thank you for the invitation. Thank you for the words. And I'll try to show a very brief case, not too long, but very interesting thing to expect sometimes in the aneurysm surgery. It's very interesting to see that sometimes in clip wrapping it's possible to develop the Muslinoma or textiloma, so-called, since a long time ago, in complex aneurysm. Next, please. We present the case report of 48 all female sex, progressive decrease with visual acuity of the left eye and headaches. We performed all of the examinations with MRI, CT scan, and visual field We try to see what happened with this kind of symptoms, because we try to despite a tumor of a vascular lesion in the huge, normally the huge size, to develop brain compression. Next, please. We discover this kind of lesion. They are very huge aneurysm. Next. And it's very, very interesting to see a very, very huge aneurysm of the internal carotid artery left. And sometimes in different angles of vision of the angiography, it's possible to see, in theory, perhaps, very wide neck of the aneurysm. And it's not so clear in the distal portion of the internal carotid artery, which is separate or not from the wall of the aneurysm. So we decide to perform for the first time the treatment, the surgical treatment of the aneurysm, and for example, to develop a bypass to be much more protected into the brain. But in the operative field, next please, we discover this kind of lesion, a very, very complex lesion, because very close to the optic nerve, very thin optic nerve, very damaged nerve, and very, very complex aneurysm. It's not possible to recognize the distal portion of the carotid artery, very dysplastic artery, as you see, and the proximal part of the carotid artery is the same thing. So we see a very huge mass, like a tumor, and it was not possible to recognize the neck of the aneurysm, despite several attempts to dissect, and very risky, high risk dissection and rupture, intraoperative rupture, with very fatal consequences. So we decided to use the very, very ancient technique to wrap the aneurysm. It was not possible in this case to associate a clip wrapping, but sometimes it's possible to do. And we decided to use different kind of materials. And for this time, we use a carotid patch with cellulosa, nitrocellulose, to cover the surface of the most of the aneurysm, and in the middle part of the aneurysm to cover with Gore-Tex, with another product that is possible in vascular surgery to use to develop bypasses. So next, please. It's possible in a close view to see what happened with the relationship in the optic nerve, very thin and very damaged nerve, you see. In part, this is very white, not with the arachnoid in the cover of the surface of the nerve. And you see the cellulosa patch with the carotid cellulosa patch covering the surface of the aneurysm. Try to respect the distal portion of the carotid artery near to the bifurcation. Next, please. It's possible to see in the middle part of the optic nerve the Gore-Tex product to cover the part of the aneurysm in the medial part of the brain. Next. This is part of the study of the visual field from the first time. The patients impair a lot, next, and only conserve the nasal part, the inferior nasal part of the visual field, next. And one month after of this treatment, we were very surprised about the results, because we don't expect a very huge inflammatory reaction around the aneurysm with thrombosis of the aneurysm, and also included the thrombosis of the internal carotid artery left. Unfortunately, we have a very permeable of the ACOM artery. Next, please. And it's possible to see by a crossflow to all of the field of the right MCA and the left MCA. So without symptoms of the patient, unfortunately, but the pathophysiology of this you see in the MRI and the CT angio. It's possible to see a very huge thrombosis of the aneurysm and also the internal carotid artery. So a very huge inflammatory reaction due the use of this kind of materials was developed around of the aneurysm, and we obtained a thrombosis of the aneurysm in the way of progressively thrombosis, not suddenly thrombosis. This is very, very interesting to see. Next, please. This is another study of the angiography. You see how with a crossflow it's possible to feel the MCA left, and you see the complete thrombosis of the aneurysm and the internal carotid artery without symptoms. Next, please. You see another image of the angiography. It's very interesting. You see by a crossflow. It's something like the ligation in the ancient used in the neck, ligation to the internal carotid artery. And unfortunately, I repeat, we have a very, very important crossflow in order not to damage the left brain with a very huge infarct and die of the patient. Next one. This is the field after the operation. We conserve the inferior nasal field, and we don't obtain any recovery of the another part of the visual field. Next, please. The clip wrapping is a very, very ancient technique, but actually we develop with different kind of modern materials. You put perhaps to ensure part of the wrapping much more close to the aneurysm, like the blister aneurysm, for example, and it's possible to associate the clip and the wrapping around. And it's possible to see through the wall of the aneurysm the development of a very huge inflammatory reaction through the wall of the artery and the aneurysm from outside of the artery, and develop a very huge inflammatory reaction and thrombosis inside of the lumen of the artery. That is what is discovered for the vascular, general vascular and cardiovascular surgeons. And since a long time ago, normally in the patch of the aortic arc surgery. Next one. This is the histopathology normally that will reveal a mononuclear cell, clear mononuclear cell infiltration, and a lot of fibrosis inside and around of the retaining material. So this is normally the thing that we can observe in this kind of lesion, retain the foreign body inside and around a very huge and very wide inflammatory reaction. Next one. A lot of hemostatic elements normally are introduced inside of the CNS, but we have inflammatory reaction normally, but in not so extensive manner. But normally the gel foam, the Surgicel, and a lot of materials that's commonly used in neurosurgery, we can react in this kind of manner. But the textiloma is only described when it's possible to use different materials that we use in vascular general surgery. The histologic examination typically shows a core of degradation, inert hemostatic agents around by inflammatory reaction. So the foreign body that we can introduce from outside to inside of the artery is possible to thrombose the artery, to thrombose the aneurysm, and sometimes to thrombose the parent artery also. Next one. Normally, all of the cases of resorbable or not resorbable hemostatic is possible to develop the textiloma. The textiloma is the word from ancient. A long time ago was called textiloma because normally we try to use the muslin, cotton, and different kind of ancient materials. But normally, the synthetic materials may be left in place during intracanal procedures. Actually, we use silicone coated sheets. It's possible to use perhaps some things that similar to the dura mater clothes in the compressive surgeries. That is possible to substitute for repair of dural defects. These agents normally and other foreign substances that are normally introduced in the central nervous system may induce an excessive inflammatory reaction. So this is the reason of the physiopathology reason that is possible to develop inside the thrombosis. Next, please. Yes, as a part of what happened with papers. There we have not a lot of papers about this subject, but it's very interesting to demonstrate what happened with the MRI. Sometimes in this kind of patient, we think, for example, in apparent artery narrowing occlusion, sometimes it's possible to see abscess inside, sterile abscess in 3 patients, for example, optic neuropathy in 2 patients. So In this part, it's possible that this inflammatory reaction promote different kind of lesion around of the brain, around of the arteries normally, not only to thrombose the aneurysm. So we must take in mind this kind of pathology, because if you decide to put this kind, or perhaps to use this kind of technique, it's possible to develop this kind of lesion in the future of the patient. Next, please. Next one. This is part of some papers. Normally, the Muslin wrapping for intracranial aneurysm, it was used for a long time ago, but the arachnoiditis, normally near to the optochiasmal region, was reported in 1978. Was with a very catastrophic loss of vision, because the use of Muslin, this kind of material, is very, very dangerous. But actually, next please. Actually, we report since 2019 the use of polyglycolic acid sheets in a thin wall of arteriosclerotic middle cerebral artery aneurysm. So this is part of the armamentarium of the vascular neurosurgeon, and it's possible to combine with very modern materials without the very severe inflammatory reactions, with not huge inflammatory reactions, but it's possible to take in mind to use. So it's possible to clip, sometimes not. Sometimes it's possible to put this kind of material and to add a clip, like a lot of very well-known neurosurgeons use it commonly, and without very severe inflammatory reaction. Next one. This is another example for another patient. You see, very interesting to put the Gore-Tex tube that is possible to use in bypassing, normally in general surgeon and vascular surgeon. And it's very interesting to put like a hat near to the dome of the aneurysm. In this case, you see pre-op and post-op. It's possible to reduce by thrombosis of the dome of the aneurysm. So this kind of material, that Gore-Tex, is not so severe like Muslin and other kind like cellulosa or another thing. So it's possible to use. You cut the tube and to put around of the aneurysm in order to try to cover, to wrap with much more safety. Next one, please. The combination of wrapping and clipping, using sometimes collagen impregnated with Dacron fabric. This is another thing. But Dacron, like the cellulosa patch for the carotid surgery, normally develop a very huge inflammatory reaction. We have a lot of papers in the actually, because it's possible to see and to combine the both technique of clipping and to try to cover the aneurysm when it's not possible to clip, or perhaps it's very, very dangerous for the patient to try to do different bypasses and so on. Next one, please. The things is very important to take in mind is from outside, we can develop this kind of inflammatory reaction. And sometimes actually we try to do by neurovascular, endovascular procedures. It's the same thing with different materials. So you can promote the thrombosis from outside, like from inside in neurovascular procedures, normally in endovascular procedures. So it's very interesting what happened from outside of the wall of the artery or the aneurysm and from inside. It's the same thing with different materials. Surprisingly, most of aneurysms associated with pre-aneurysmal edema are unruptured, but they normally appears like a very huge tumor. So we must to treat like a tumor to try to aspirate inside and to try to clip if it's possible. Next one. Normally the rupture after the wrapping occur in 12% in some papers in some series. Normally the ischemic complication reported only is 3.5%, and granuloma is only 1.5%, only 1%, near to 2%. That is very, very interesting to see. It's a very rare complication But in this area of the aneurysm and this kind of techniques, we must to think about when we see a patient with progressively deterioration of the visual field, headaches, and mass effect in the brain. Next one, please. In conclusion, textiloma may be a complication in wrapping clip surgery and rupture of not ruptured aneurysm, 1.5% with visual loss in internal carotid artery region. Surgery and endovascular show the same inflammatory reaction. Dacron and cotton muslin were the most frequent materials, less with Gore-Tex. And bleeding in non-rupture, very rare, more common in rupture in 12% approximately. Next one. In conclusion, when a patient with a history of wrapping with aneurysm present with neurological symptoms and enhancing intracranial mass in MRI, we must to think about the muslin-induced foreign body inflammatory reaction. We must to consider the muslinoma or textiloma in part of our diagnosis. Next one. Perfect. Thank you so much for your attention.
Thank you very much, Professor Cordoba. It's really a very, very interesting case. You show it's very important. Even it gets more and more infrequent because of the new techniques, to solve giant and difficult aneurysm. We have to keep in mind that in very special and difficult aneurysms, the possibility of clip wrapping is still one tool that we have to manage as neurosurgeons. As you showed in this very interesting case, there are a few, but there are reports. I remember in a report in Journal of Neurosurgery of a Korean group of 5 cases of Muslinoma, very, very similar as you showed. And we have to know that this is possible to have this granuloma or inflammatory reaction to external tissue or materials that we use in our surgeries. So it's really very, very interesting, and I think it will be very very important for young neurosurgeons to keep in mind this technique and the possibility of this complication as well. Thank you.
Thank you, Claudio. I understand and I completely agree with you. And the last case was in here, and it's not possible to show because we have not enough time to show that. But we have a very, very young, 10-month-old baby that we use the same in a very complex Sylvian aneurysm. And was not possible to clip. In part, yes, it's possible to clip, but we use the cover with Gore-Tex. So I think it's part of our strategy of the neurosurgical vascular procedures, and we must to keep in mind every time.
Thank you very much, Alvaro. I think I don't know if there is a question or any other comment.
I am open every time for the questions.
There's no questions in comment box, but
okay.
I'm glad to say that it was a great pronunciation and great presentation, and thank you so much, Doctor, to presentate for us. And well, all viewers, don't forget to make your registration, link in the comments box. And so, Dr. Lima, I don't know if you want to say something.
Thank you, Doctor.
Okay, so a pleasure to see you. See you soon.
Perfect. Thank you so much, Claudio. Thank you so much, all of the organizers.
Thank you, everybody, and stay safe.
You too. Thank you so much for the organizers also. Gracias, Claudio. Un abrazo.
Chao, Álvaro, que sigas bien. Abrazo grande.
Cuídate por ahí, por favor. Cuídate.
Cuidado, cuídense. Todos.
Sí,
chao,
todos.
gracias. Abrazo grande.
Muchas gracias, doctor. Muchas gracias.
Chao, muy amable.